My name is Sanil Pathyil, and I'm a third-year professional pharmacy candidate at Florida University. Today, I'm going to be talking to you about the comparison of pregabalin with pramipexole for the restless leg syndrome. The background of this is that dopaminergic medications relieve symptoms of the restless leg syndrome, also known as RLS, but have the potential to cause iatrogenic worsening augmentation of RLS with long-term treatment. Pregabalin may be an effective alternative. The objective of this is that in this 52-week randomized double-blind trial, we assessed of efficacy and augmentation in patients with RLS who were treated with pregabalin as compared with placebo and pramipexole. The trial design is patients were randomly assigned to receive placebo of 0.25 milligrams pramipexole per day, 0.5 milligrams of pramipexole per day, or 300 milligrams of pregabalin per day for 12 weeks in capsules that were identical in appearance. After which, patients receiving placebo were randomly assigned to one of the three active treatments for the remainder of the study. Medication doses were increased over the first 2 weeks of the study to the final fixed dose. The pregabalin dose was based on the results of a prior dose-finding study. Before randomization, patients discontinued all RLS medications for at least 1 week or 5 half-lives, whichever was longer. This period was followed by a 1-week single-blinded placebo run-in. Thus, all study participants discontinued their RLS medication at least 2 weeks before starting the study medications. Medications were all administered orally 1 to 3 hours before bedtime. The use of concomitant RLS medications was not allowed. Visits were scheduled at the start of treatments and at 2, 6, 10, 12, and 14 weeks after the start of treatment. Thereafter until the end of the study, which was 52 weeks from the start of treatment. Visits were monthly. Patients also completed daily logs of symptoms during the weeks preceding each visit. At the end of the study, the review board evaluated possible cases of augmentations by reviewing double-blinded information consistent of entries from patients' logs and efficacy and augmentation data compiled by clinicians. The determination of whether a case qualified as augmentation was based on the unanimous agreement that established criteria had been met. The review was performed before the study group assignments were revealed. The location of this whole thing was in the United States and in Europe. It was approved by all institutions, review boards of participants' institutions. The inclusion was that the patients had to be above 18 years old, had to have moderate to severe primary restless leg syndrome. Symptoms occurred at night. Symptoms onset 6 months before diagnosis. Symptoms present at night greater than 15 days before diagnosis. And IRLS score was greater than 15 at the beginning and end of 1 week placebo run. Exclusions of this was that they had prior reports with augmentation. The primary endpoints were comparison of pregabalin with placebo, change from baseline to 12 in the RLS score, patients with a CGI evaluation of much improved symptoms, change from baseline to week 40 or week 52 in a percentage of participants with augmentation. Secondary endpoints was patients reported measures included limb pain as assessed on a visual analog scale, quality of life with RLS as assessed in a questionnaire, sleep as assessed on a subjective sleep questionnaire, and at each study visit, the participants were asked to complete the Columbia Suicide Severity Rating Scale for suicidal ideation or behavior. Follow-ups visits were scheduled at the start of treatment and at weeks 2, 6, 10, 12, and 14 after the start of treatment. Thereafter, until the end of the study, 52 weeks from the start of treatment. Comparison of pregabalin and placebo over a period of 12 weeks based on the International Study Group Rating Scale. Comparison of pregabalin and pramipexole over 40 to 52 weeks period, assessing improvement of symptoms through a clinical global impression of improvement scale. Comparison of pregabalin and pramipexole over 40 to 52 weeks period, assessing augmentation of RLS. And this whole thing was a duration between December 2008 and June 2011. The population was a total of 719 participants who received daily treatment, 182 with 300 milligrams of pregabalin, 178 with 0.25 milligrams of pramipexole, 180 with 0.5 milligrams of pramipexole, and 179 with placebo. The control group was obviously the placebo, and the intent to treat population was pregabalin 300 milligrams, pramipexole 0.25, and pramipexole 0.5. The statistical analysis was that step 1, pregabalin versus placebo for the IRLS score over a period of 12 weeks. Step 2, pregabalin versus placebo for the CGI evaluation over a period of 12 weeks. Step 3, pregabalin versus 0.5 milligrams of pramipexole for augmentation over a period of 52 weeks. Step 4, pregabalin versus 0.25 milligrams of pramipexole for non-inferior efficacy over a period of 12 weeks. Step 5, pregabalin versus 0.25 milligrams of pramipexole for non-inferior efficacy over a period of 52 weeks. Step 6, pregabalin versus 0.5 milligrams of pramipexole for non-inferior efficacy over a period of 12 weeks. Step 7, pregabalin versus 0.5 milligrams of pramipexole for a non-inferior efficacy over a period of 52 weeks. Step 8, pregabalin versus 0.25 milligrams of pramipexole for augmentation over a period of 52 weeks. The primary endpoints were after 12 weeks, patients who received pregabalin as compared with those who received placebo had a significantly greater reduction, which is an improvement in the IRLS score, and a greater proportion of patients in the pregabalin group had symptoms that were reported as very much or much improved on the CGI evaluation, which was 71.4% compared to a 46.8%. As compared with placebo, the 0.5 milligrams dose of pramipexole, but not the 0.25 milligram dose, was associated with a significant reduction in the IRLS score and a significantly greater proportion of patients with improvement on the CGI evaluation. Pregabalin had less augmentation compared to pramipexole at a dose of 0.5 milligrams, but not at a dose of 0.25 milligrams per day after 52 weeks. Secondary endpoints are that the evaluation of secondary outcomes for active treatments as compared with placebo after 12 weeks were outside the step-down testing procedure. Statistically significance was therefore not assessed. Greater improvement in several measures of sleep with pregabalin than with either dose of pramipexole, including waking after sleep onset, quality of sleep, number of awakenings, and total sleep time. In contrast, a reduction in time it took to fall asleep was more pronounced with both doses of pramipexole versus placebo than with pregabalin versus placebo. And now we're going to go into some adverse events. The rate of study discontinuation due to adverse events was lower in the groups receiving pramipexole, 18.5% for those receiving 0.25 milligrams and 23.9% for those receiving 0.5 milligrams. Then for the groups receiving pregabalin, which was 27.5 milligrams. With pregabalin, the most common adverse events were dizziness, somnolence, fatigue, and headache. Pramipexole, the most common were headache, nausea, and fatigue. For adverse events leading to study discontinuation, the most common events were somnolence, dizziness, and with pregabalin, and nausea and headache for pramipexole. 50 serious adverse events occurred during treatment and were reported in 37 patients. 11 events among those receiving pregabalin, 20 among 0.25 milligrams of pramipexole, 12 among 0.5 milligrams of pramipexole, 5 with the placebo to pregabalin, and 2 events among those who switched from placebo to pramipexole at a dose of 0.25 milligrams. There were also 11 cases of suicidal ideation. 6 in the group receiving pregabalin, 3 in the group receiving 0.25 milligrams of pramipexole, 2 in the group receiving 0.5 milligrams of pramipexole, and then there's 1 death was reported, which was a 77-year-old woman receiving pregabalin. She had a stroke. In the author's conclusion, he said that the assessment of the study's primary endpoints showed that 300 milligrams of pregabalin per day as compared with placebo significantly improved RLS treatment outcomes after 12 weeks. Significantly less augmentation at a dose of 0.5 milligrams of pramipexole per day, but not at a dose of 0.25 milligrams per day after 52 weeks. Treatment with pregabalin was not superior to treatment with 0.5 milligrams of pramipexole. Pregabalin was associated with lower rates of nausea, vomiting, and headache than pramipexole, but with higher rates of suicidal ideation, dizziness, somnolence, and weight gain, factors that may limit to long-term use. I believe this case had a whole bunch of strengths. The organization of the study allowed for easy assessment and understanding. The population being studied were explicitly stated, as well as the criteria used for assessment. The primary reason I find this to be a good study is it provides relatively easy to read data and can allow a clinician to make their own opinions regarding the effectiveness of the therapy. Some weaknesses I found in it would be if they could have another trial of this to make it more solid of factors. But overall, I thought it was a very good case. But the final summary of primary literature, pregabalin provided significantly improved treatment outcomes as compared with placebo, and augmentation rates were significantly lower with pregabalin than with 0.5 milligrams of pramipexole. Although pregabalin can be used as an alternative, an important contraindication to understand before switching therapy is risk of suicidal ideation. Therapeutic value is also lower in pregabalin compared to pramipexole at a dose of 0.5 milligrams. The application and conclusion would be that this is important when applying to cost because knowing alternative therapy can be used. This can be beneficial to certain patients because some patients may like their insurance may not cover it and they should have alternative options. Also, when giving doctors certain options, if one medication is not covered, it gives them alternative options. Well, that concludes my presentation. Thank you for listening, and yep, that's it.